Hello, everybody. It's my pleasure to introduce this webinar, an important one with presence of high-level expert, as ever, I would say. Professor Desmoulières, Dr. Sylvie Meaume, Professor Ardeshir Bayat, and Dr. Ormerod will turn around different options in scar prevention and management. I will just leave you some information concerning the next UMA JC meeting that will be held. This is a slide on the textbook on scar management, on which we had the surprise of turning around 150,000 downloads. As you know, this book can be downloaded for free. It's an open access. And coming back to the GC UMA meeting, in fact, we had to cancel the July session and to transform that into a presential session that will be held in Paris in 2022. The G-ScarS meeting will be the one organized by Professor Rei Ogawa in Tokyo in November. And in Paris, we will have a session on scarring, where it will be co-organized by different societies, and a special event on the 50 years of the myofibroblast. Alexis Desmoulières and Professor Gabiani will define exactly what was done 50 years ago and what transformed our view on the biology and also on the treatment and prevention on scarring. So have an excellent webinar, and hope you will enjoy.
Okay, thank you for the introduction. So again, hello everybody, and welcome everybody for this last webinar before summer, before vacation for some of you, I hope. So do not hesitate to use the YouTube chat to first to tell you from where you are watching the webinar. It's important for us. And also use this YouTube chat to ask questions to the speakers. So our platform will gather your questions, and the speakers will be answering to you live after their lecture. So do not hesitate again to use the chat to interact with us and with the speakers. It's important for everybody. So now I introduce the first speakers, and Dr. Sylvie Meaume, which is working in Rothschild Hospital in Paris, France. So Dr. Meaume is a dermatologist, also involved in internal medicine, gerontology, and allergo-immunology. She is head of dermatogeriatric department and wound care unit in Rothschild Hospital. And she is also lecturer at the Sorbonne University of Medicine. She was in charge of the direction of several theses on advanced wound care management and epidemiology of chronic wounds and dermatological problems, mainly on elderly people. She has produced more than 100 publications indexed in PubMed, again on wound healing, scar, management of pressure ulcers, venous leg ulcers, dressing assessment, nutrition, again, especially in elderly people. She's co-founder of the French Journal on Wounds and Scarring and of the Journal of Wound Care. She's co-organizer of the French National Meetings on Wounds and Healing, which take place every year, a big meeting every year in January in Paris. It's an international meeting. She is co-organizer of the Academy of Wound Technology in Europe, Asia, North America, and Middle East. And she is a vice president of the French Society of wound healing. So, Sylvie, you can begin your talk. Thank you.
Thank you very much. I try to share my screen. Share. I do again. Sorry. Yes. I do. Thank you, Alexis, for this very kind introduction. Oh, sorry. Yes. The topic today, as dermatologist, is for me easy to treat, but it's not so easy for all dermatologists. You know that all over the world, dermatologists can be involved more in cosmetic and other more involved in internal medicine. And it's not so easy for every dermatologist to treat or prevent scar. And I think it's an important thing to try to train a young one in this field. As introduction, I would like to talk about a little bit of history of dermatology and history of scars. I show you this lovely picture of an elegant lady, a Parisian Madeleine Lescaille. This miniature is a color engraving, and you show on the upper part of the thoracic region keloid scars. And Madeleine Lescaille was very proud of these scars. Alibert was the first professor of dermatology in Paris who described keloids and treat. We have in Paris a molding museum at Saint-Louis Hospital in Assistance Publique Hôpitaux de Paris, where I work now. And Professor de Vergy, at this moment, at 68, was head of the Department of Dermatology and collect watercolors and expenses illustrating the main dermatological pathologies, and we have in a lot of books this color picture available. Another professor of dermatology, Professor Lallier, also head of the Department of Dermatology in Paris, discovered a famous molder, Jules Barretta, who developed a wax casting technique and made numerous moldings that can still be seen today in the museum in Saint-Louis Hospital. You can visit that, and there is a cupboard full of this molding and full of more than 20 molding of scars, hypertrophic and keloids. But come back to the practical things. An important thing is to remember the natural scar evolution and what we have to say to the patient. First of all, when they ask the dermatologist about their wounds and ask for a scar after, we have to say, yes, you have a wound and it leads to a scar. But a pathological scar, hypertrophic or keloids, it's not a defective scar. It's not a problem of surgeon, of dermatologist. It's pathological scars. It's a problem of the patient frequently. Who are patients at risk? Usually, you know, black and mixed skin or Asian skin or young age or adolescence or pregnancy, hypertrophic and keloid scars are more frequent. You have also areas at risk for pathological scar, lower part of the face, ear lobes, upper thoracic region, and pre-sternal region. Before operation, a famous question that the patient asks is, I need to have a surgical procedure. What can I do to make my scar looking good? I don't know if we can give some recommendation about the role of emollients. We have not a lot of evidence-based medicine, but usually in cosmetic surgery, sometimes the plastic surgeon and dermatologist recommend in the 2 weeks before the operation to put emollients. an important thing is that everybody is okay to say to the patient is stop smoking, usually forever, almost for the weeks before and after surgery. After, an important thing is also to closely check the freshly sutured wound and the beginning of the scar. For the patient, we have recommendation to wash the suture of the wound with mild soap every day, to recommend shower, to dry, but not rubbing the wounds or the scars beginning, but dabbing with clean, soft and dry clothes. Use protective dressing, but not always, not all the time, but it's essentially to prevent contamination and also to protect the skin or to prevent contamination. An important thing is to remove stitches approximately 5 to 6 days on the face to prevent hypertrophic or anesthetic scars, and 2 to 3 weeks on the rest of the body, for example, after hip replacement or fracture. In terms of prevention, the quality of the surgery is important. Most scar pathologies are linked to mechanical forces. We know that since years, but Ogawa remembers that in a famous paper in 2010. We respect the Lange lines. It's learned during the surgical residency and it's learned to the young dermatologists, but we have to remind that frequently. Another important thing is to have a subcutaneous suture of good quality. And frequently, we recommend also to make suture tension-free or use this new medical device, for example, the zip one, and you increase the quality of the scar. After, there is some general preventive measure if the risk of abnormal scar is low. The use of emollient is recommended immediately after closing, 3 to 4 times a day. It's recommended if you have not to apply sticky or silicone bands, or in case of you have very low risk of pathological scars. Usually you have to use an hypoallergenic moisturizer, and the application of thermal water and spray or on the gauze is also recommended. Sun protection is very important, and at least for 1 year, as long as the scar doesn't match the color of the surrounding skin. It's very important, and I explain to the patient there is a risk of post-inflammatory pigmentation, and you have to protect your scar from the sun during several months, usually during 1 year. And the protection you use must be over 50, and it's better than to use a cream to use clothes. When to be alarmed, when and who to consult. The warning signs are not the same if you have patient, usually it's redness, pain or pruritus, and if you are a doctor, nurse or physiotherapist. Usually the medical population is more worried about the volume of the scar. Who to consult? Usually you have to consult for the operator, dermatologist, surgeon. It's medical legal during the first month after surgery. But it's also possible to consult directly a dermatologist after 1 month, after 1 year sometimes, or after. And usually we know that now the patient consult Google doctors in internet, essentially. What recommendation we can have? First thing is the use of non-silicone occlusive dressing. Hypoallergenic tape, usually in polyurethane, adhesive microporous, are widely used. It's not expensive. There is several uncontrolled case series that show results in favor of their use. And the role, which is a preventive one, is supposed to reduce the risk of hypertrophic scar after a routine surgical incision in patient at risk, but low risk, essentially in young patient, or if the patient have a family story of abnormal scar. Another solution is the use of hydrocolloids. You know, this adhesive breathable hypoallergenic dressing, largely used in the management of wounds, can be used also in prevention of abnormal scar. And for example, it's recommended on the children after burns, essentially to control tension, eliminate friction, protect from ultraviolet, and prevent hypertrophic scars. It's not so expensive usually, and the patient have to wear 4 to 7 days, and even during bath or shower, and it's relatively easy in very young patients. But the real revolution in terms of management of scar is the largely use of silicone gel. And you know that the silicone was used in the management of scar since 80s. But at the beginning, that was essentially silicone dressing. You have different size, different thickness, different product, usually medical device, not reimbursed. In France, we have only one, which is reimbursed, and not since long time. And you have to use this dressing only when the wound is totally closed. So you use after 2 weeks, for example, to avoid skin reaction, because at the beginning, frequently you can observe some inflammation under this dressing. At the beginning, you have a recommendation to apply for 1 hour per day, and after you increase progressively, and the patient has to wear the dressing a minimum of 12 years per day, and at best 24 hours, and except for shower and bathing. The dressing required daily maintenance, washing the dressing with neutral soap, and usually change the dressing after 1 month when it presents a laminated appearance, and it is too old and you have to change. The real revolution is the silicone gel or spray, and also the possibility to include some screen into this gel or spray, especially to put on face or hand, and obtain a better compliance with the patient. The application is usually 1 or 2 times a day, as long as the scar is inflammatory, and sometimes you can use more than for several months. We have a lot of evidence-based. You have Cochrane, which is not very recent, but the recommendation of the use of the silicone gel is on immature scars, which are the one who respond best as the action of the silicone. Usually you observe something after 4 weeks. If you don't observe nothing, you can stop usually. 80% of the patients usually are responders, and sometimes the benefit is modest in some cases, but usually the benefit is visible. You can use on normal scar, but also on hypertrophic and keloids, even you have not a lot of evidence based on these special abnormal scars. There is some contraindication, essentially the fragility of the skin, which is not so frequent, and if you have a suspicion of infection. Some side effects are sometimes seen, some rash, some maceration, and usually you have to stop to apply the dressing of the gel and to reintroduce, usually after some days, progressively, and usually you have not the reappearance of this adverse event. There is very rare true allergies. We also, as dermatologists, largely use laser for scar, ablative or non-ablative. Sometimes we use a laser at the beginning, sometimes after, to decrease inflammation, to correct color, to reduce the risk of hypertrophy. It's dependent on the dermatologist and the aspect of the scar. When you have a problem, when you have an hypertrophic or keloid scars, dermatologists largely use corticosteroid infiltration. Since the 60s, there is a large consensus to use a triamcinolone injection, at first intention in keloids, second line in hypertrophic scar. The efficiency varies between 40 and 70%, and you can observe a recurrence after years, between 10 to 50% after 5 years, but usually it's the first treatment we propose to our patient. Practically, you have to put 2 hours before MLA cream or use application of liquid nitrogen just before injection. You have to inject strictly in an aseptic zone, use sterile glove, iodine, and you have to inject strictly scars, tangential injection, and usually, because it's very hard to inject, by removing the needle. You can use a needle for subcutaneous or mesotherapy, or you can also use dermojet. We prefer to use screw syringes because it's really hard to inject these hypertrophic or keloid scars. After you have to apply a dry dressing, usually you stop the silicone dressing or gel during 1 or 2 days, and you reintroduce after. We do this corticosteroid infiltration once a month, and usually we see results after 2-3 injections, and we propose to the patient first series of 10 sessions. Some complication, especially on black skin, is depigmentation due to the use of steroids. Another use of the steroids is steroid tape. Is recommended by Gutos and Ogawa, and there is a not so recent publication, but not so old. And it's a daily application of the dressing that deliver steroids over 6 to 8 weeks, and there is no systemic or effect reported, including when you apply these steroid tapes on children. Another drugs you can inject strictly intrascar, another chemotherapy, is 5-fluorouracil. 5-FU is also a treatment for hypertrophic scar and keloids. Usually it's on hospital. You make this intralesional injection in monotherapy or in combination with corticosteroid injection. You also have another chemotherapy, inject bleomycin. It's depends on the product you are available. Usually it's in hospital. You use this 5-FU because it must be prepared the day of the injection and deliver according strict rules. The use of small dose is now replaced by high dose of 5-FU. The number of the syringes usually pharmacists prepare depends on the area, volume to be infiltrated. The technique is the same than the corticoids injection, but it's more painful, and you usually has to add, for example, hypnosis or MEPA or things like that to control pain. Usually, the combined treatment, steroids, triamcinolone and 5-FU, during some months, conduct to better result. You have some contraindication just linked to the 5-FU, which is a chemotherapy, drugs who can give infection, thrombocythemia, leukopenia, anemia, immunosuppression, and which is contraindicated in pregnant women. Another device that dermatologists use is a cryotherapy. Since years, local cryosurgery with edema, immediate bubble, and hypopigmentation was done, but you have sequel and you have recurrence. So we change and go to contact surgery, cryosurgery, intralesional cryosurgery, and we have some experience with a cryo-shape technique, and an example on this publication done by Chopineau and Hando Martin in Caen with the cryo-shapes, which is intralesional cryotherapy for this here scars. Frequent treatment we use is the association of cryotherapy and triamcinolone. Cryotip or local application of cryotherapy for 10 to 20 seconds when the scar is very hard, not for hypertrophic. Usually we use for keloids, and injection of triamcinolone in association. You have the role in terms of management of pain and prevention of pain of the cryotherapy and additional treatment. Side effect, which is frequent, is bubbles, hypo or hyperchromia, pain or atrophy, linked to cryotherapy and TAC, but both probably. The additional advantage is for me, I use frequently in keloids, the anesthetic benefit of use of the cryotherapy. For example, the facial scar is very important. We do sometimes such scars when we remove cancer, skin cancer, which is very frequent on the face, but it's also post-traumatic. The problem is to discuss the use of glue or strip versus zip or stitches, and try to prevent anesthetic scars. The most important thing for me is to remove the stitches early, not after the first 5 days, and put just after strip or silicone or hydrocolloids. Usually at the beginning, we use first strip, hydrocolloids, and then silicone. For example, on this young girl, after a handball match, she opens here the skin, sorry, and put some points and suture, and after we remove, the suture, and put immediately after a strip along the scar. Not perpendicular, but along the scar, and let this small strip, or we can put also a part of hydrocolloid dressing or a silicone dressing. And after 2 months, the scar is not bad, and we can continue with hydrocolloids or strip, or change and comes to, for example, silicone gel. The problem of scar is sometimes only a problem of aesthetic. And a possibility is to make up the scar. Esthetician can give some example to patients, and you have on these young girls after burn a good result of the makeup. It's learned in burn center or in oncology unit, for example. And for other wounds and other scars, not usually after a cancer, but after another type of wounds, for example, surgical or a traumatic one, you can tattoo, and you have some good result, just like this one. The problem of surgery for pathological scar must be also considered, and you can remove keloid. The problem is the technique. Do you use an intra or extra excision of the scar, or sometimes you have to, for example, here to make small flap or to cut the line, to cut the scars. The important thing is that dermatologists must work with the plastic surgeon and contact them to try to find the best solution with a combination of the medical treatment and the surgical one. Finally, to summarize my topic, sometimes you have immature skin, and usually we manage that with laser. Atrophic skin is not really frequent, and you have some solutions. The best one is probably the fat injection or fractional laser. If you have an hypertrophic scars, the use of silicone is now all worldwide recommended. Cryotherapy, steroids, centrifuge, ablasive laser or surgery, but surgery after 1 year, not less, can be recommended. For keloids, silicone is also recommended at the beginning, radiotherapy in some countries available, steroids, centrifuge, ablasive laser, surgery, and sometimes association of surgery and radiotherapy, surgery with steroids or surgery with centrifuge can be recommended. After burns, special scars occurs, and there is some recommendation. You find here also silicone, which is recommended, compression garments, and it's very important that the physiotherapist works with this patient, fractional laser and surgery, but also after, essentially, to obtain a good result in terms of function. There is a lot of recommendation, guidelines, and you find a lot of literature on that topic. Sometimes the guidelines are focused on surgery, on injection, on laser, on silicone. The last one was in surgery by Ogawa. You have a lot of things and some recommendation because we have not enough evidence base. So in conclusion, even since the past decade, we have more ESCTs performed and a big increasing knowledge in this area. It's important to have recommendation from the clinician. It's possible now with all this literature and also with the group of SCAR people involved, dermatologists, surgeon, and physiotherapists, for example, to build algorithm to treat abnormal scars and train the young doctors in these fields. It's important to develop prevention. I think an important thing is to put an adhesive bandage along the postoperative scar for 3 months in subject at risk, which is probably the more easy things to do. Also to educate the patient on the benefit of hydration and occlusion and photoprotection. It's the role of dermatologist. And also recommend the large large use of silicone. We have a lot of literature on this topic, and I think worldwide it's now recommended to use and select probably dressing or gel and spray. It's depend on the location and the type of scar. Combination treatments are progressively developed. It's more efficacious and there is less side effect. So I thank you very much, and now I'm waiting for your question.
Okay, thank you very much, Sylvie. Again, welcome to everybody. We have participants from many countries all around the world, and so welcome for this webinar. So we have time for some questions. A first question from Teddy Prasetyono from Jakarta in Indonesia. So, Sylvie, you see the question, what is the rationale of applying emollient before surgery, because inflammation takes place after surgery?
Yes, absolutely. I explained there is no evidence on that, but frequently I think people recommend to use emollient before to expect they put emollient after. And also, it's essentially for the patient a problem of psychology to probably accept more some change in their body on their skin after surgery. When they have no wounds or no tumor visible, but you have to open to make an extraction of big tumor behind, the patient are very anxious about the surgery. To give them something to do before surgery is important, and after you can probably propose more easily a treatment to apply after the surgery on the scar.
Okay, thank you. And now a question from Eugène Adai from Ghana. What about old scarring from previous surgery?
I'm also a geriatrician, and I see very old people coming back to me 20 years after surgery and ask me questions about their scar. Sometimes it's a problem of aesthetic. They have personal problems to resolve, and they ask for increase the quality of the surgery. Sometimes some hypertrophic or keloid scars becomes more pruriginous after some years. We don't know exactly why. Usually it's usually in summer and in association with the hot weather, and we can make some recommendation. But it's always possible to put silicone. It's always possible to make injection of corticosteroid and 5-FU if you have an old scar which is not aesthetic or comfortable for the patient. But don't forget that sometimes when the scar is changing after years, to consider perhaps behind there is a cancer and you have to make biopsy.
Okay, a question from Igor Safonov from Sweden. Do you have any positive results using Mepiform against hypertrophic scars and keloid scars?
I don't use frequently Mepiform because it's not available in France, and we have another one which is reimbursed. We use more frequently KELO-COTE and KELO-COTE UV, and I have no personally result with Mepiform. But I know it's usable. You are in Sweden, it's more like a product you use probably.
Okay, a question from Venison Chelapen from Mauritius. Does an addition of corticosteroids to silicon dioxide important in treatment of scar keloids more than 1 year?
Addition in injection? No, I understand. Yes, I think sometimes you can use for more than 1 year in some patients without any problems.
Okay, so maybe now last question. What techniques, it's a question that is important for me. What techniques for massage would you recommend for hypertrophic scar?
Yes, it's depend of the scar. If it's a burn scar, or if it's a post-surgical scar, for example, or if it's after surgery or not. You have different techniques. You can use LPG and what we call the palpé roulé, which is techniques that physiotherapists use largely. You can use all that. It's not specially recommended for hypertrophic scar. Hypertrophic scar was not treated by massage. It's essentially adherent scars. It's essentially scar after burns or after surgery to try to improve the quality of the scar and reduce tension. It can be used for hypertrophic scar if it's not painful, I think.
Okay, so many thanks. We have to go on. And sorry for the other question. So now I introduce thank you, Sylvie, again. I introduce the next speaker.
Ladies and gentlemen, I'm honored.
So Professor Bayat, who is a clinician, a scientist, as well as a principal investigator. He is co-director of the Medical Research Council Wound Healing Unit at the Division of Dermatology, the University of Cape Town in South Africa. He is also co-lead at the Wound Healing Biomedical Research Center, Plastic and Reconstructive Surgery Research, and Center for Dermatology Research in University of Manchester in England. So his research work is focused on the subject of skin repair, rejuvenation, and regeneration. So he has published a lot of paper, original paper, review articles, book chapters in this field. He's a grant reviewer for many research councils, and he currently sits on the editorial boards of several journals related to areas of expertise. So his research is organized around a multidisciplinary and interactive research environment that exists between the bedside, so in clinic and hospital, the bench, in laboratory, and industry. So, Professor Bayat, I think it's a registered video, but Professor Bayat will be there to reply to your question at the end of his talk.
Ladies and gentlemen, I'm honored to have been invited to deliver this presentation on this clinically and scientifically important topic, preemptive prevention of skin scarring pre-surgery. During this short talk, I will discuss skin scarring spectrum and talk about various phases of healing and focus on mast cells and their relevance in scarring. Discuss EGCG as a candidate for modulation of scarring and mention our previous studies of note. Discuss the concept of preemptive skin priming with relevant evidence. Go into detail of the methodology to evaluate our double-blind randomized clinical trial and discuss in detail some of the findings with a summary. Acute wound healing requires activation, synchronization, and tight control of multiple interrelated, overlapping biological phases known as hemostasis, inflammation, proliferation, and remodeling, as depicted in this busy diagram. The failure of any of these components can result in either delayed healing or indeed abnormal scarring. In order to objectively evaluate the response of any potential anti-scarring therapy in human skin, a number of approaches are taken, and certainly histological analysis of biopsy tissue remains the gold standard for assessment and diagnosis of normal and pathological wound environments using gene protein studies of relevance. In addition, we also use quantitative non-invasive imaging tools with remarkable cellular resolution for monitoring skin changes over the course of the study and observing for responses that we can delineate to topical intervention. Over the years, mast cells' role in wound healing has been studied. In the inflammatory phase, vascular permeability is induced by histamine released from activated mast cells. There is degradation of the extracellular matrix and recruitment of neutrophils. In the proliferation phase, collagen synthesis and fibroblast proliferation, as well as epithelialization, are all induced, and alpha SMAs are regulated. And angiogenesis is further stimulated, and histamine stimulation, production, and contraction of alpha SMA. In this busy slide of temporal biopsies of human skin healing, we demonstrate sequential time points over an 8-week period of time of mast cell release into the wound and scar environment in human skin. Chimeras was significantly higher at weeks 1 and 2 and showed 98% reduction at week 8. Gene expression analysis also supported this. Mast cells reside in intact skin and also in scars. My group has previously conducted an immunophenotyping study in nearly 100 KELO-COTE that showed increased expression of mast cells in intralesional and perilesional kelocytes and higher numbers of degranulated mast cells, implicating their potential role in this chronically inflamed and fibrotic disease. Epigallocatechin gallate is the most popular and potent member of the catechin family of polyphenol. My group to be a key player in modulating scarring and was found to reduce mast cell numbers significantly in various skin scarring models employed in a number of studies by my group, from normal scars to KELO-COTE as depicted here. We previously conducted in a 62 human volunteer double-blind randomized clinical trial involving sequential biopsies using a unique proprietary formulation containing EGCG against the placebo, that there were significant differences between the active and the control side in volunteers. Indeed, the results showed that the application of EGCG resulted in reduction of mast cells as well as blood flow, whilst there was an increase in elastin content, but importantly, a reduction in scar thickness. However, these findings were carried out at the time of, by our study at the time was, our study focused at the time of injury, or indeed application of the topical 2 weeks post-injury. But in view of these incredible findings, we postulated that preemptive application of this particular active may indeed prime the site of injury and lead to a better outcome. Examples of studies supporting the concept of preemptive skin scarring prior to an invasive intervention for achieving an optimal result have been displayed in this table here, although our approach appears to be the first for using a topical for moderation of scarring pre-surgery. Preemptive priming of the zone of injury prior to performing excisional punch biopsies was evaluated in a double-blind randomized clinical trial using a temporal punch biopsy model. Clinical quantitative devices were used to objectively monitor cutaneous healing at weekly intervals, and punch biopsies were performed for protein and gene expression analysis. Participants were split into 4 groups indicating different modes of topical application, primarily comparing pre-injury to post-injury. Pre-injury comprised of either applying the topical 3 days or 7 days pre-injury, as opposed to applying the topical post-injury on the day of injury, or delayed application for 14 days. This busy slide is a methodology overview for this double-blind randomized clinical trial, which shows a comprehensive way employed to validate and corroborate any finding using non-invasive quantitative biopsy tools, imaging tools, as opposed to validation of gene and protein profiling performed on biopsies over these temporal time points. Our mast cell analysis data using mast cell tryptase showed a significant reduction post-ECG, EGCG application was seen in the pre-injury model compared to immediate and delayed topical application. And importantly, these findings were corroborated by gene studies as well as protein immunohistochemical findings. The tryptase findings were then further corroborated by using a mast cell kinase assay, which showed equally interesting and statistically significant reduction in the mast cell numbers in the pre-injury model, pre-injury priming model compared to the immediate and delayed topical application. Another assay performed to corroborate the previous finding was the c-KIT assay, which again showed a significant reduction in the number of mast cells post topical application in the active group compared to placebo, shown most significantly in the pre-injury model. So in addition to the mast cell findings, we focused on blood flow and angiogenesis. Here depicts examples of the human volunteer biopsy images that were taken sequentially from week 1 to week 8. And really the findings speak for themselves, as there are obvious clear differences between the pre-injury model and the post-injury, comparing active to placebo. So if you look at the columns and which are depicting the temporal time points compared to control, and the rows group 1 and 2 are the pre-injury compared to group 3 and 4, which are the post-injury. So these images were then further corroborated by looking at blood flow using laser Doppler in the pre-injury and post-injury biopsies. Again, most of these images speak for themselves, although all these images were quantitative and statistically evaluated and showed clear differences between the pre-injury and the post-injury model. To further corroborate this, we also used dynamic optical coherence tomography, which looks at that microcirculation in the wound and scar environment, which showed a statistically significant and similar trend to what was obtained before. So in addition to the blood flow results, we wanted to look at angiogenic markers of relevance, and in particular, we looked at angiogenic marker CD31, which is shown to be mostly downregulated in the pre-injury priming model, as shown in the protein confirmatory studies comparing placebo to EGCG application, which shows a marked reduction in staining, and that was further confirmed by the gene studies of relevance for these models. Another angiogenic marker of relevance, VEGF-A, was equally and significantly downregulated in the pre-injury priming model, as shown in this busy slide, showing reduction in staining before in the pre-injury model compared to the post-injury, comparing placebo to the active topical application, all of which was then further confirmed by gene confirmatory studies. So in addition to the concept of looking at mast cell reduction as well as angiogenic reduction, we wanted to look at the role of EGCG in antioxidant levels. We know that EGCG has a very potent antioxidant role, and this was shown in our previous published study. Here again, in support of our previous findings, and indeed, unsurprisingly, we showed that the antioxidant levels were significantly enhanced by the presence of the EGCG in our model. So importantly, of note for scarring, we were interested in structural analysis of our biopsied samples. So initially employing a non-invasive tool, a high-frequency ultrasound, 50 megahertz high frequency, showing here groups, group 1 at the top, group 4 at the bottom, and we're seeing temporal biopsies, scans, and here we see confirmed trend in scar thickness reduction, which was equally confirmed histologically by performing measurements on H&E slides. Of note was the increase in content of elastin content shown by one of our clinical non-invasive tools, an elastin probe, which measures viscoelasticity. So these corroborated by performing and identifying elastin content using gene and protein confirmation. Here in the slide, we see an increase in staining post-topical application of the active compared to placebo in the elastin content, which was corroborated by gene confirmatory studies. So, in summary, ladies and gentlemen, this unique study of comparing pre-injury model comprising of 2 separate dates, 7 days before performing an excisional biopsy, compared to an immediate application of topical on the day of injury, as opposed to 2 weeks after injury, show remarkable differences of preemptive priming of the skin or the site of injury, both a 3-day and a 7-day model, and the results indicate by applying this topical, you gain an incredible advantage by reducing the number of resident mast cells, as well as inducing a reduction in angiogenesis, as well as in a reduction in scar thickness, but simultaneously increasing elastin content as well as antioxidant levels. I'd like to thank you for your attention, and if you have any queries and you'd like to get in touch with me, please either email me on my UCT email or on my Manchester account.
Okay, thank you, Ardeshir. Okay, I don't know if you hear me.
I hear you well. Hello, can you hear me?
Yes, it's okay now, thank you. I have a question concerning mast cells. It has been suggested that mast cells are involved in the scarless situation observed in fetal situation. So it seems that the appearance of mast cells induces the appearance of scar during development. What is your feeling?
Yes, that's a very interesting point. It's a very relevant point. We believe that mast cells are one of the key regulators of scarring. And the difference between modulating mast cells as opposed to modulating neutrophils and macrophages is that there are no untoward effects in terms of prevention of infection and the ability to mount a response. As you know, when we wound, we're not in a sterile environment. So it is clear that any modulation impacting significantly the presence of neutrophils and macrophages can be detrimental, whereas reduction of mast cells seems to improve the outcome because mast cells are not detrimental to the process of repair, but their presence can actually aggravate the process of scar formation.
Okay, thank you. And it's the same type of question concerning angiogenesis. So angiogenesis is necessary, but you induce a reduction of angiogenesis. So how?
Yeah, angiogenesis goes hand in hand with inflammation. When we talk about inflammation in a wound, we're not abrogating angiogenesis. Angiogenesis is critical. And this is the thing about making claims about, I suppose, giving a topical that can erase scarring. That is possibly, that cannot be possible unless you ameliorate a process. What we're doing here is reducing the cargo load by mast cells. As a result, there is a reduction in angiogenesis. And as a result of the reduction in angiogenesis, or what we term angiogenesis, it also includes the whole inflammatory process here. You're also reducing the impact on the eventual outcome, i.e. Abnormal scar formation, or the total load of mast cell release that can impact on the angiogenic component.
Okay, and your observation concerning elastin are very impressive. So usually elastin reappear long time after the damage, and here you obtain elastin expression again quite rapidly. So you think it's a direct effect, or what is the mechanism?
Well, it's difficult to explain as a direct effect rather than the fact that we have a reduction in scarring and the fibrotic component. It may make the elastin content appear more, as it were. So if you have less scarring, you have more elastin to begin with. And it may just be, we can't be sure whether the topical application has a direct role on the elastin, but what we're observing is that there is certainly an increase. And what is evident is that, well, there is an increase because you have less scarring, so you have more elastin. And the ideal scar is where you have more elastin and less fibrotic component in terms of contractile element and call 1 to 3 expression.
Mm-hmm. And you have some idea about the reduction of the modulation of fibroblast, myofibroblast differentiation?
Sadly not. I think that is a very important topic to look at. And, one of the hardest things with human trials is the sort of scarcity of samples and what we could look at. And sadly, in this very sort of, so these biopsies are very small, and we had to perform quite a number of studies, including gene and protein, as well as RNA sequencing, because we were very interested in seeing what happens to the entire pathways that could be impacted by the application of EGCG. So that question will need to be answered in a follow-up trial in more detail.
Okay. Many thanks, Ardeshir, and good afternoon in Captain. And thank you again. And now I go to the next speaker, and I introduce Dr. Jonathan Ormerod. So some words. After graduation in molecular biology, Dr. Ormerod first joined the pharmaceutical industry in 1989. After a few years, he left to pursue business interest in the automotive industry and yacht racing before returning to pharmaceuticals in 2000. And since then, he has been principally involved in musculoskeletal and autoimmune diseases. And after receiving a master's in health economics in 2011, he was responsible for the technical and economic challenges associated with successfully bringing biosimilar monoclonal antibodies to the UK pharmacopoeia. And now Dr. Ormerod is joined the company Alliance in 2019 and is a senior scientific advisor responsible for a broad portfolio of products, mainly in dermatology and associated conditions. So many thanks, Dr. Ormerod, and please present your talk.
Thank you very much to you, Professor Desmolières, to Dr. Theo, and to G-ScarS for the opportunity to make this presentation. So, I guess, you know, without further ado, we've known for many, many years that early intervention, and particularly in the at-risk individual, is an important step in preventing the progression of hypertrophic and keloid scars. Silicones have been an effective and convenient part of any preventative strategy ever since the first guidelines were published back in 2002. And as we've seen from Dr. Meaume's presentation, here we have the...
Jonathan, you're not sharing your screen.
It's not changing the screen?
No, you're not sharing your screen.
I'm not, I should be.
Yes, it's okay.
Gabriel? Yeah.
Yeah. Okay.
Sorry. Yeah. Okay. So yeah, as we see here, this is the 2014 guidelines, and here we have as Dr. Meaume was said, you know, practicing good technique and wound management to reduce the risk of scarring is an important part of that. But we can also see that silicones are showing a role to be had for both high and increased, and also in concerned patients. So there is a number of places where silicones can be used. Although they play a less prominent role in the treatment of older and perhaps more severe scars, particularly as the newer treatments and techniques have been developed, I think it's true to say that silicones can still be used as adjuvants and successors to other treatments in those particular areas. So what is it exactly about silicones that gives them their the ability to be able to work in this environment? So it's thought that the most common theory now is that it's to do with transepidermal water loss, and you can see on the cartoon on the right hand side here that there is localized transepidermal water loss through the area of the scar, and possibly through a change in osmotic gradient, whatever it is. The upshot of that is that there is an activation of keratinocytes, which then leads to an increase in pro-inflammatory cytokine release, and that in turn leads to increased and more haphazard collagen production by dermal fibroblasts. Now, one of the things that's important to point out is that there's no direct evidence of a direct action of silicone gel on scarring, because scar biopsy studies have shown that there is no silicone within the area of the scar. However, the most commonly recognized theory these days is that there is an optimal healing environment which is caused by occlusion and hydration of the area around the scar. This leads to a reduction in transepidermal water loss, which in turn normalizes cytokine production and collagen production by fibroblasts. It's also possible that there is a very localized increase in temperature in the skin, which may enhance collagenase activity. And this has been demonstrated in this particular animal study. Here we have a rabbit ear model of hypertrophic scarring, and various different products, so KELO-COTE, Cavalon, and Indamil, were compared to tape stripping in this particular study. And it was shown that there was a significant reduction of transepidermal water loss using these products compared to tape stripping alone and compared to a control. So it would appear that transepidermal water loss does have an important part to play in this. As far as KELO-COTE is concerned, KELO-COTE is a patented technology. It uses a number of different silicon components within it. So firstly, there is a volatile silicone that evaporates across a temperature gradient when it's applied to the skin. This means that the remaining material dries very quickly within sort of 5 minutes. And also within that, there is a silicon dioxide component which cross-links between long-chain silicone polymers to create a very, very thin, semi-occlusive layer of silicone gel over the area of the scar. This is permeable to oxygen, but it's impermeable to water. Now, the really innovative part of this is really that because of the oily nature of silicones, because of its drying properties, it allows it to create this transparent occlusive layer that remains attached to the skin for a prolonged period of time. Looking more towards the clinical evidence for KELO-COTE, we have a couple of studies that I'm going to show you here. The first is a randomized study in 30 patients. They had, each patient was their own control, so they had immature bilateral scars, hypertrophic scars, or keloid scars. And for each of these, one scar was treated, the other was left untreated. Patients were assigned to one of 3 groups. So either KELO-COTE was applied morning and evening, silicone gel sheeting was applied during the day and left in place morning and night, or KELO-COTE was applied in the morning and a silicone gel sheet was applied at night. The evaluations that were looked at included redness, height, and softening of the scars. And we can see here that both silicone gel sheeting and KELO-COTE caused a reduction in scar height. So about 1.5 millimeters with KELO-COTE and about 1 millimeter with silicone gel sheeting, compared to barely any reduction in scar height with no treatment. When we look at other properties of scars, such as erythema, we can also see that compared to the untreated control scars, over the period of the study, which was 90 days, the treated scars in both the silicone sheeting group and the KELO-COTE group had significant reductions in erythema. And lastly, in this particular study, we also found that there were reduced symptoms of itching and irritation of skin. Sorry, there's a typographic error there, irradiation. And skin maceration after 90 days of treatment, both with gel sheeting and with KELO-COTE compared to no treatment at all. However, one of the things that was found was that patients found the silicone gel, as opposed to the gel sheeting, much more easy to use. And as a consequence, they found that adhering to their regimen was much, much easier with KELO-COTE. Now, this is an important part because in order for silicones to really work to their best abilities, it's important that they're applied for as much time during the day as possible and for continually during the period of treatment. This second study was conducted in 80 patients with KELO-COTE and 80 patients who had no treatment unless they started to show signs of hypertrophic scarring. The main causes of surgery were benign or malignant skin lesions, which needed excision by Mohs surgery, but there were also a number of individuals who had scar revision and cosmetic surgeries as well. KELO-COTE was applied twice daily, and treatment was started from between 10 days and 3 weeks after the surgery, continuing for 4 months. Patients were evaluated using a 4-grade scale over the 6 months of the entire treatment period, so that would be including a follow-up period. And you can see here that about 2/3 of the patients had a grade 1, were classified as grade 1, who were treated with KELO-COTE, which is effectively no scarring at all, compared to 28% of the patients who had no treatment at all. And when we get to the more severe scarring, you can see that the numbers who were treated with KELO-COTE had very, very low numbers of severe scarring. So we had 6 patients with grade 3, and 1 patient only who had a keloid scar, which was the grade 4 classification. One of the benefits of the KELO-COTE range is that there are a number of different products within it. So in addition to just the gel, we also have a a gel containing a sun protection factor. So sun protection factor 30 will absorb up to 97% of UVB radiation. Clearly, all the guidelines recommend avoiding exposure of wounds to the sun because of the effects of ultraviolet radiation on skin pigmentation. So having this is, again, an additional benefit of the KELO-COTE range. This is a very small study with some photographic evidence here of patients who were treated with KELO-COTE UV. We can see here that there's very, very little excessive pigmentation after 3 months in this scar here. And also below the eyelid, again, this is a barely recognizable scar after 3 months with no signs of excessive pigmentation or reduced pigmentation. Lastly, there is also a spray within the KELO-COTE range, and we conducted a study in patients with split thickness grafted burn wounds, looking at the effectiveness of KELO-COTE spray in treating these particularly large and difficult to treat wounds. So in this particular study, what we had was patients were treated with compression garments and KELO-COTE spray versus compression alone, or compression garments and silicone gel sheeting versus compression alone. Treatment was continued for 12 months, and the outcome measures were largely the Vancouver Scar Scale, an additional assessment of mechanical assessment of scar redness and height as well. And there was long-term follow-up for 18 months. Pictorially, we can see over here that there is definitely a visual improvement in the appearance of the scars. So we're seeing reductions in redness, reductions in height during the course of 12 months. But this was happening both using compression and KELO-COTE. By and large, the study didn't show any significant differences between using compression garments with or without silicone. However, one of the things that we did see was that as far as the adverse events that were reported, KELO-COTE spray and compression compared to silicone sheet and compression was showing significantly lower records of adverse events. The sort of adverse events that we were seeing were largely skin maceration and contact dermatitis. So in conclusion, KELO-COTE is an advanced silicone spray. It forms a gas-permeable, water-impermeable layer which assists in the normalization of transepidermal water loss through scar tissue. The fast-drying silicone layer is a property which is down to the particular formulation and the use of volatile silicones within it, and KELO-COTE will dry on normal temperature skin within about 5 minutes. The efficacy of KELO-COTE is comparable to silicone sheets. However, one of the things that we find from the studies that we've seen is that there's less skin maceration, greater patient acceptability, and as a consequence, there is likely to be better patient adherence to the treatment. And the beneficial effect of KELO-COTE has been in the prevention and treatment of scarring has been demonstrated in a large number of studies involving more than 1,900 patients. And I thank you for your attention.
Okay, thank you very much, Jonathan. I have a question. Do you think so? It is clear that the mechanical microenvironment of the scar, of the wounds, is very important to modulate the action of the cells. Do you think that silicone can also have an action to modulate the mechanical environment?
Can you can you expand on your question a little bit more, please? So, are you talking about its ability to perhaps reduce tension around the scar?
Exactly.
I mean, there have been, I believe, there have been some studies where that's been used. Obviously, with any of these things, they're not that physically strong. So I know that there have been 1 or 2 studies where silicone gel sheets have been used with taping over the top of them to bring reduced tension over the site of the scar. I don't know whether that would be possible with something that is as thin as using a silicone gel, because whilst it's relatively mechanically strong, it's obviously very, very thin indeed. So you would have to apply something on top to have any mechanical effect at all.
Okay. So the results using silicone are impressive usually, but the mechanical of action is quite mysterious maybe. So there is a question from Igor Safonov from Sweden, I think. Please explain, again, mechanical of action. Please explain how transepidermal water loss is associated with the synthetic function of fibroblasts.
To my knowledge, what happens is that the transepidermal water losses, I think it's largely down to there could be an osmotic gradient between caused by the loss of water through the scar area. That has an effect on particularly TGF beta, and that in turn will lead to the recruitment of keratinocytes. The keratinocytes are the cells that will ultimately lead to recruitment of additional dermal fibroblasts.
Okay, a question from Eric from Ghana, I think. In countries of the use of KELO-COTE UV gel compared to a normal KELO-COTE silicone gel?
Anywhere where there is a significantly higher UV intensity, it would be certainly worth using an ultraviolet cream over the top. I mean, I think it's recommended that you use those sort of sunscreens in those areas anyway for prevention of abnormal pigmentation of the scar. But the UV would certainly be more beneficial than just the ordinary gel. Yes.
Okay, a question from Laura, Cambridge, UK. Can scar message be used alongside silicone gel treatment?
No reason why it shouldn't be. No, absolutely not. I mean, I think probably massaging the actual gel is not really what you want to be doing, because all you need to do is to apply it to the scar area. So it's not a question of massaging the gel in, because it lays on the surface. So massaging might be something you want to do for something that's being absorbed to the skin, but silicone gels are not absorbed into the skin. So massaging as an additional means of assisting in the scar healing is certainly beneficial. But then once you've done the massaging, that's when you would apply the gel.
Okay. You mentioned that silicone has an action on itching. Okay. Mm-hmm. Do you know if silicone has an action on pain?
There's less evidence for an actual action on pain. So, I mean, certainly there's been some work with where we've seen studies where it's been used in keloids. There has been a reduction in pain and itch, but it's not as convincing evidence as there is just to the itching that's associated with hypertrophic and other scars. So pain is a difficult one, I think.
Okay, so thank you very much again for your talk, and I have now to close this webinar, and just I can remind you that during summer, so we stopped this series of webinar, but in September we hope to begin again this webinar with all of you and more than all of you. And thank you very much again to everybody, and good summer, and see you soon, I hope.